Gail?
Okay, I have a couple slides. So I'm a PI both in the. It's going to help. Thanks. It's still early Seattle time. I'm a PI both in the CSER and eMERGE network, so I appreciate Rex introducing eMERGE for me, and I'm just going to say a couple words about CSER. It is a national consortium to put clinical sequencing really into medical practice. Most of the results here were done in the CSER 1 funding cycle, and a new funding cycle has just begun, but the slide you're looking at represents the initial cycle, because those are the results that I'm talking about today. And I think these slides will be available, but the marker paper, which has the PMID up there, summarizes a lot of what the consortia did. And if I could have the next slide, one of the things that the consortia did in the next slide after this, thank you. With the eMERGE, we wrote a joint return of results paper talking about updating return of results for genomic testing. And really, the floor and the ceiling sort of give scopes of what should be returned. The consensus here was that, first of all, people should be able to refuse to get their genetic results. And it's funny, we keep hearing about, oh, people really love these results. But the people that we talk to in genetics clinic are the ones who love these results. And as a clinical geneticist, many of us have had the experience of people saying like, oh, you know, my sister's at 50% risk for this BRCA pathogenic variant, and she just won't deal with it. Well, those are the people we don't talk to, and those are the people who have a high risk and still don't want the information. So those people are out there, and they should be allowed to decline to get this information. They shouldn't have to get it to enroll in studies, unless, of course, the point of the study is return of results, and then there's a trade-off that the results should be valid. And so we talked about that with CLIA. It doesn't have to be CLIA, but it has to be right. You have to have reasonable certainty that this is a useful, correct result. And the floor was medically actionable. That was the minimum of what should be offered back, is what is medically actionable. And the ceiling could be everything. And I'm going to refer you to the paper for more details. And I should have said there were like over 120 authors of this paper, and the writing group is represented on the slide, and a bunch of them are here in the room. What didn't we agree on? We didn't agree on whether adult onset results should go back to pediatric research participants. And this is the place where the generalizability of genetics sort of falls apart, because genetics, unlike many other medical tests, has implications for family members. And so the argument for returning those results to pediatric patients is actually that they probably got that variant from one of their parents, who then should be aware of the result and that it's in the child's best interest. But another voice was that the child should be able to make that choice as an adult. The other place that we didn't agree it was on whether it was legal to return non-CLIA results, and that was before Barbara Evans wrote her very exhaustive legal piece on advocating that that is legal. And I know we lost Barbara from this meeting because of her house being flooded in Houston, but I think she's an important voice, and I hope people look at her work. Another thing that we did in CSER was to ask participants in focus groups what kind of results were they most interested in. And in particular, we're focused on things that you're not expecting to get, which some people call secondary findings. We actually did some study of what term participants like, both in Seattle and at UNC, and they preferred the term additional findings to secondary findings and incidental findings, so maybe we'll listen to them and start using their term. But anyway, what they prioritized was things that were treatable, so they cared more about finding out about a result if it was going to be treatable, things that were severe, things that had a high lifetime risk, so as a geneticist I would think of that as high penetrance, and things that had a family impact. Those are the things that the participants were most interested in hearing about. We returned results to patients with family risk of colon cancer at our site, and we returned not just colon cancer related variants, but also these additional findings So that could be a breast cancer result, for example, pharmacogenetics and carrier results. And we did this in 2 separate visits. We did the colon cancer first and everything else in a second visit to try and help people sort through them. And what we found that was interesting is when people, even though they had sat with a genetic counselor in person for the first visit, when they came back for the second visit, they still had questions about that first result. They were not ready to move on to the next result. And so I think it speaks to just how complex it is for people to understand some of these results, that even after an in-person visit, they had a lot of questions about their results very consistently. The other issue that we saw was there became a confusion of roles, because actually our genetic counselor sometimes spent more time with the patient than their clinical genetic counselor, and all of these patients were seen in a medical genetics clinic. That's how they were referred to the study. The patients were calling our genetic counselor for general care questions, not the clinical genetic counselor. And so this question of who is your care provider and who is doing research is very hard for the participants to separate. Another concern that we found is that the doctors, this has been talked about a little bit before, the doctors really don't know what to do with some of these results. And in fact, we've seen doctors do things with the results that we felt were inappropriate. And so that's, a problem not just with having the doctors explain the result, but what happens when this goes into people's medical records and their health care. In our eMERGE study, we went back to a biobank that we had and asked them, these are people who had enrolled for genomic studies, but without the expectation of getting results back, because those initially were enrolled for GWAS studies. We didn't really expect to get anything interesting to them back. So we reconsented, and they also had agreed to broad data sharing. So we reconsented them, 2,400 people, and asked them if they wanted return of highly penetrant, medically actionable results only, not any other kind of results, and those results would go in their electronic health record. And only about 50%, 51%, so 1,226 out of 2,400 sent back the consent form agreeing to this. So half the people didn't, and we don't know why most of them didn't, because it's passive. We just didn't get the consent form back saying, yes, I want to do that. We did get calls from about 47 people, which is about 2% of the cohort, and they called to express why they weren't not interested in enrolling in this. A bunch of them didn't want it in the electronic health record. Unfortunately, the timing for us was a little poor because it was right after the election, and people were worried about GINA being repealed. And so we had people call and say, well, I would have done this last year, but I'm not doing it this year because I'm worried that GINA won't exist anymore. There were some people that were concerned about the impact on the results on their family members. They didn't want to have to explain that there was something genetically different about them that might put family members at risk. And then there were just people who were just simply not interested. And those were even people who called to say, we're not interested. I'm sure there are a lot of not interested people who were not even interested in calling. And I should have mentioned that these people didn't, because the way the study was designed, they were not going to have any costs for getting medical care around the return of these variants. That was written into the healthcare system's support of the research we were doing. And I thought this was interestingly concordant with the CSER finding from the UNC group, which is that a high proportion of their people consented to return of results, but they had an additional step that people had to actually call to get the results, and many, many of them just never called. So even though they said they wanted it, they didn't actually take the step of picking up the phone and dialing to get them. And so I think, again, that speaks to how interested people are actually, how much work they're willing to do to get the results. As I said before, I think genetics doesn't generalize to other issues, in particular for pediatric testing of children, but really this whole relatives being at risk thing. And one thing that we did see in these studies was that the pathogenic variants we found in our research participants, their family members would get referred then for more clinical testing. We worked in a CLIA environment, but I strongly advocate, and I've had other studies where we've returned non-CLIA results that were then followed up with the offer of clinical CLIA testing, and certainly when family members get further testing, those are all CLIA. So I guess I'll stop there and see what questions people have.